Welcome and thank you for standing by. At this time, all participants will be in a listen-only mode. After the presentation, we will conduct a question-and-answer session. To ask a question, please press star 1. As a reminder, today's conference is being recorded. If you have any objections, you may disconnect at this time. I will now turn the meeting over to Ms. Melissa Lake Spencer. Ms. Lake Spencer, you may begin.
Good afternoon. The National Ombudsman Resource Center would like to welcome you to our webinar, Ombudsman Advocacy, the Impact of Mental Health Issues. This call is being recorded and will be available from the center. There will be an opportunity at the end of the call for questions. There will also be an opportunity to participate in an exercise early in the presentation. I'd like to thank you all for joining us today, and I'm going to turn the call over to Sarah Hunt, the center consultant. Sarah?
Thanks, Melissa. And hello to all of you. I miss seeing the smiles on your faces, but are delighted that you can join us this afternoon. And we are particularly excited about having Dr. Susan Wehry be our presenter for this call. As all of you are living with, there are always issues and questions that come up related to mental health for residents and as well as for ombudsmen and how to deal with the issues. And I think the issues that we here at the center that you are encountering keep getting a little more challenging and difficult every year, and you see a growing number of them. And at the same time, you see maybe less responsive community mental health services in your areas as well as from the state mental health perspective. So we continually go back to Susan and ask her to help us learn more, know more, and be better advocates in this area, both to change systems and to make life better for individual residents. Melissa sent you a list of some resources that the center has on this topic related specifically to ombudsman work. Those are on the Ombudsman Resource Center website, and she sent you the links to those. One I particularly want to point out is the Mental Health Ombudsman Training Manual that was developed for the New York State Long-Term Care Ombudsman Program by Dr. Wehry, and it's an excellent resource for ombudsmen. There are 2 PowerPoints on the Ombudsman Resource Center site right now from that curriculum, but the New York State program generously has agreed to let us make it available to local ombudsman programs or state ombudsman programs as needed, and each state already has 1 copy. If you need a copy of that or want one, contact the Resource Center. Eventually, it will be on our website, but isn't up there right now. As many of you know, Dr. Wehry is a board-certified geriatric psychiatrist with additional qualifications in geriatric psychiatry. She's worked in a lot of different fields in state government. She is an excellent advocate herself, and she's been working with ombudsmen for quite a few years. She works with ombudsman programs in various states. Many of you have had her in as your conference speaker, as well as she's helped us nationally many times. She also works a lot with other entities such as nursing homes. She's been very involved in the Pioneer Network, as well as working with the Veterans System and with the Department on Aging in Vermont, as well as a whole slew of other people. But most importantly, Susan is a wonderful advocate and really understands the ombudsman work and has always been very generous in helping us learn more. So I want to just say 1 or 2 more things. One is, as you listen, be thinking about your specific questions, because as you heard earlier, there'll be a time at the end of the call for you to ask questions and to really use Susan as a resource. And also think of very concrete, specific kind of situations that you can listen to her presentation and think about, oh, this is how I can deal with this. Or if you want to fine-tune that, you'll have an opportunity to ask a question later in the presentation. We will post PowerPoint on the website in case any of you had difficulty with the attachment. And without anything else, I would like to turn it over to Susan.
Thank you very much, Sarah. And thanks to all of you who are on the call. I really am so grateful for the opportunity to meet with you this afternoon and to share with you my thoughts and experiences about how to be good advocates for residents with mental health conditions, and also to hear from you what you would like some help with I was commenting to Sarah and Lori, Melissa, and others before we began today about how grateful I am as a psychiatrist, as an advocate, as a person who's concerned about populations that have historically been marginalized. I was complimenting NORC, the National Ombudsman Resource Center, for always paying such good attention to mental health. And I just want all the ombudsmen on the call to know that the credit was turned right back to you. They were joking and saying, well, even if we didn't want to address it, the ombudsman would make us, because these are the questions and concerns and problems that they're confronting. And, my feeling is whatever brings you to this call today, I know that one thing that brings you to the call is a wish to do better by residents who have mental health concerns or whose mental health concerns are impacting others. Long-term care environments, in my experience, just keep becoming more and more diverse. I've been at this for about 30 years, and over the course of the last 20 of those 30 years, I think, I've often been asked to talk about and to address mental health issues. But in the past, that was mostly being asked to address mental health issues faced by seniors themselves who were living in nursing homes and who also had mental health conditions. Increasingly, I think we're being called on to assist younger individuals who have psychiatric disabilities, as well as older people with psychiatric disabilities, as well as people of all ages with traumatic brain injuries and older persons with dementia. Now, I used to call this talk, or one sort of like it, What's Different and What's Not. And I used to call this talk What's Different and What's Not to emphasize my opinion that ombudsmen already know a lot about how to advocate for people with mental health conditions, because you already know a lot about how to advocate for people with dementia. But as you can see on your screen or on your slides, I've changed the title and am now calling it Bad Reps and Bum Raps to emphasize what I see as a growing problem in the field, and that is that once you hear the label, or once nursing homes hear the label, behavior residents, psychiatric disabilities, mental illness, schizophrenic, immediately some prejudices, assumptions, and biases come up, and people who bear those particular labels, I fear, come into long-term care facilities already with bad reputations. And what I mean by bum raps is that they are more likely to face sort of challenges to their fundamental residents' rights, and they are more likely to challenge that sort of unexpected or mandatory discharge. So my focus, or my passion that I bring to this afternoon, is as a special voice for people with psychiatric disabilities, not to the exclusion of people without psychiatric disabilities, but rather to broaden the family of people in long-term care, to include those who suffer from serious mental illness, traumatic brain injury, dementia, any of those mental health conditions that significantly impact a person's ability to peacefully coexist. So this webinar, I hope, will in fact help you understand, make better sense of communications as they're impacted by mental health problems, enable you to do advocacy well, and as both, I think, Melissa and Sarah have indicated, to give you an opportunity to pick my brain and to raise your questions at the end. Now, to begin, I want to look at what I mean when I say what you bring to the long-term care environment, what skills you already bring. And then I'm going to describe to you some of the situations that have already been reported to me and reported to the National Ombudsman Resource Center, talk to you about the general questions that we'll pose today to kind of get you thinking about your cases. And then at the end, we'll hear directly about some of the very specific cases. Before we do that, I'll review some of the common features of mental health conditions I want to make sure I describe the recovery movement to you today, and then I'll also make a few remarks about the assessment of capacity. Now, what you bring, in my experience, what ombudsmen bring to this conversation is a great deal of optimism. And in this enterprise, the most valuable resource that you bring is you. And I mean that quite sincerely. In my experience, ombudsmen have an incredible can-do kind of sensibility. Ombudsmen also bring a conviction that you're doing the right thing and that you want to do the right thing. You see things that can and must get better. You have commitment, you have energy, you have increasing knowledge, and in my experience, increasing sophistication in how to advocate in a sometimes non-responsive system. You have good communication skills that are already built on knowing how to listen. So what you bring to the person with a mental health problem, a psychiatric disability, a cognitive impairment, however you frame that, are all of these skills. Some of what you face, and some of what you have to face with those skills are the situations in which you find that the resident's rights may be in conflict with what the facility says is their necessary behavior plan. And I'm thinking here of those situations in which you, coming from a resident's rights perspective, appropriately, are faced with a facility telling you that they must abridge the resident's rights, take things away, for example, in order to change their behavior. We're going to talk about what you do in the face of that. We're going to talk about what you do in the face of what, quite frankly, are very antiquated approaches to dealing with people with mental health problems. In the example that I just gave you, the example of negative reinforcement, I indicated that sometimes you'll be told taking something away is necessary to change a person's behavior. But quite frankly, negative reinforcement programs not only are inappropriate from a rights standpoint in someone's home, these are, after all, not treatment facilities, they are homes. They secondly have been shown not to work. They simply don't work well for this population, the adult person with a psychiatric disability. Whether they ever work with young, developmentally disabled children is up for grabs, but I can assure you they don't work for this population. So you're up against sometimes staff using an approach that you have a suspicion might not even be that helpful. And in addition, you have concerns that it impacts on people's rights. I'm also hearing and experiencing myself a kind of resurgence of us and them. There's a wish to see people with mental health issues as somehow different from the rest of us and needing to be locked away in some special place. Kind of a return to the old specialized institution facilities, because the culture change, quite frankly, does not seem to have yet quite caught up to creating livable environments for people with psychiatric disabilities. They're still very stuck in the medical model of specialized treatment facilities, as opposed to comfortable living environments for people whose disability might be psychiatric. And it's leading a little bit to some of this us and them. And so that's something you're up against. You're up against dealing with people who sometimes have aggressive and threatening behaviors. And these might be aggressive towards you, threatening towards you, or aggressive towards other residents, or aggressive towards staff. And being an advocate for somebody who is perceived as a danger to themselves or somebody else, or, importantly, do seem to pose a danger to you, makes it enormously challenging to do your job. We're going to talk about aggressive and threatening behaviors as well. And then something I hear a lot about is the conflict between balancing the rights of what are called the old residents against the rights of the young residents with psychiatric disabilities usually. What I the way I've reframed that, if you see on your slide, is what sometimes boils down to a conflict really between the physically frail and the physically fit. And it could be of any age and of any condition. But oftentimes what I hear is, I know this young person with psychiatric disability has rights too, but their behavior is dangerous for these people in wheelchairs. Without challenging the truth or not of that sentiment, let me just say that what is at issue there, I think, has more to do with issues of mobility and physical fitness than the psychiatric disability. And I emphasize that because I want us to always remember that what we have to get back to is, who is this person? Not the category of persons they belong to, but who is this individual? What do they need? And what do they need in this context as they live with others? So that's a little reframe of the way I'm usually asked it, but that's my explanation as to why I do it that way. Now, given some of those usual situations, these conflicts with behavior plans and residents' rights, antiquated mental health or a non-responsive mental health system, aggressive behaviors, and so forth, some of what I think we're going to address today is, what do you do with all that? In other words, how do you proceed? If you're in the information gathering phase of trying to solve a problem and trying to, plan how to resolve it, who should participate in that? Who participates within the home, within the community? What are the community resources that might be available? And what do you do if the community mental health system refuses to be helpful? What are some ways that we can compel them to be helpful, or encourage them to be helpful, or invite them? In other words, what I hope we're going to talk about today is all of the tools you have in your toolkit, so to speak, that everything is not just about having an adversarial forcing somebody or about regulations, but when we need them, we use them. There are ways to engage people in a cooperative way. When do we use those? And who are the participants that are likely to increase that participation in problem solving? And then again, as I say, always back to this issue of struggling with the rights of one and the rights of all. Now, a moment ago, I said to you that ombudsmen bring a lot of skills already to the table in this. You bring optimism, conviction, hope, knowledge, experience, and so forth. You also bring assumptions, prejudices, past experiences that may not contribute positively. And to proceed, so before we proceed, I'd just like to bring some of that to the fore to help us think about the way we think about the people we serve. So for this exercise, what I would like you to do is to close your eyes, because closing your eyes actually helps you see better when you're trying to reflect. So close your eyes, and I'd like you to think about a resident that you know, that you've been involved with, who has dementia. I want you to take just 1 minute to do that. I'll let you know when the minute is up. And when the minute is up, I'd like you to open your eyes and write down as quickly as you can all the words that came to mind about that resident. A minute's a long time, isn't it? Open your eyes and write down as many words as quickly as you can, the resident with dementia. Okay, and now I'd like to ask you, if you are from a state whose name begins with any of the letters from A to D. If you're from an A to D state, press *1, and the operator will recognize you as having your hand up and will take your list. I think that's the way this is going to work. Or if you are from a state that begins with the letter W, please do the same. Press *1 and give us your words.
Once again, please press *1. Mary, your line is open.
Yes. My list of words associated with this resident is lonely, misunderstood, young, male, doesn't fit in, and aggressive.
Okay, thank you very much. Lonely, misunderstood, young, doesn't fit in, and aggressive. Anybody else? Mary, where are you from?
Alabama.
All right, there's a good A name.
Okay, our next participant is Reed Webster. Your line is open.
I'm from Alabama.
Go Alabama.
Confused, demanding, fearful, and forgetful.
Excellent, thank you. Got a good list already, but we'll take one more if there's another caller out there.
Okay, Karen, your line is open.
Hi. I have a mother, a friend, confused, scared, and a citizen, a contributing participant in society.
Okay, now and what is this citizen's contribution?
Well, she was a mother to her children, and she worked in her lifetime.
I see. You mean that she has been, and I'm not saying that she's not now. I was just wondering if she was playing a unique role in the home.
No, I mean just she was a contributing part of society at one point. And I'm sorry.
I forgot about the pause. I was just going to say I totally agree with you. I didn't mean to cut you off. Great. Thank you very much. Well, if you all were jotting them down, as I was making two different lists on my reflective exercise sheet. Now, on the left-hand side, I wrote all of those characteristics that emphasize what we might call the disability or the problem or the need. And on my other side, I wrote those that might represent the person in the kind of person-centered culture change kind of way. And I think the last person whose call we took really put a nice highlight on this for us. Because generally, when we do this exercise, this is the list that we get. It's the list of the challenges, the list of the problems. The list that includes being lonely, misunderstood, aggressive, forgetful, demanding, confused, challenging. And our list rarely has as many attributes that we might say are just about the person. So the third caller provided for us mother, friend, and citizen, contributing member of society. And that's a nice reminder and a nice way, I think, of allowing me to highlight the purpose of this reflective exercise, which is to say that if I ask you, and this is what you are most often asked by staff, if I ask you to think about a person with dementia, you will think about the person with dementia. The dementia is what will come to the fore. And you can see the difference here on the slide. The difference between seeing people as their disorder and seeing them as a person for whom their disorder, their mental health condition is secondary or is a piece of who they are. They are part of a stage that they are in or a condition that they have. And one of the biggest challenges, I think, for ombudsmen and frankly for most people in long-term care who work with people with mental illness or with mental health problems of any kind is to see the person. The person with schizophrenia is very different, a very different frame of reference than seeing the person who, oh yeah, by the way, has schizophrenia. And I don't mean to minimize schizophrenia. It's a potent and impactful condition. But the point here is that the frame of reference to do all of your work has to be starting with the person. Now let me give you an example here. I'm going to take the story of Miss Lillian. This was a person that was presented to me as by an ombudsman. And this is something that I'm calling Miss Lillian. She told this ombudsman one day when the ombudsman was visiting that she was certain that she had received the wrong medication, and that she had told the nurse that she had received the wrong medication, and that nobody believed her. So she's told you she's not going to take her medicine anymore, and wondered if you, the ombudsman, could find out whether or not she could start getting the right medication. She tells you this isn't the first time it's happened, and she's very worried that she's going to have a reaction. The ombudsman asks the nurse about Miss Lillian's complaint and is told, oh, Miss Lillian has dementia. She's just confused. You can't believe what she says. She doesn't know what she's talking about. So the ombudsman asks, could that be true? Could it be that if Miss Lillian has dementia, she might be wrong? The ombudsman says, I'm not an expert on dementia. What should I do? Could it be a delusion? Could Miss Lillian be getting the wrong medication? Getting the right medication, but just think she's getting the wrong medication, the way people with dementia will often say that somebody's stealing their purse when it's just been misplaced. So what are you supposed to do? So the way we solve this particular problem, and the way that the suggestion that I would make to you, is that your job, in my opinion, is not at the outset to give the absolute verification, is this the truth, as if there's only one, but to accept as a given that this is the resident's truth, and then to figure out what it really means. Because at this point, I don't know if she's getting the wrong medication or not in the literal sense, but what I do know, and what's most important, is that she believes she's getting the wrong medication. So my job, your job, becomes trying to figure out why she thinks that and what's happening. So what are some ways you can do that when a person does have a memory problem and you don't know exactly how well they're describing the situation? The first thing you do is to simply consider, okay, what is this person telling me? They're saying they get the wrong medication. They're saying it happens every day. They're saying they're afraid they're going to get a reaction and so forth. What are some things that you can do? Well, you could attempt to get collateral information, but in this situation, the attempt to get collateral information wasn't very successful. The nurse just dismissed it. CNA dismisses it. People aren't that invested because they are starting from the point that says Miss Lillian doesn't know her own mind or doesn't know her situation. So efforts at getting collateral information may not be that successful. You ask yourself, well, what do I know about dementia? You say, well, I know that people may not communicate directly. I know that they may be confused. They may have misperceptions. So what could we do to find out what's going on here? And in this particular situation, I recommended recreating the situation and then observing it. Basically, asking the nurse to go in with the medications that the nurse believes to be the correct one, and to, with Miss Lillian right there, look at them and say, which of these do you think are the right ones, which do you think are not the right ones, and to try to figure out what the problem is. When this was done, what actually turned out to be the problem was that Miss Lillian had started receiving or had started having trouble swallowing a particular pill. And it didn't seem to be particularly because it was one of those situations where the brand name had been changed to a generic and now it was bigger. The pill that was now too large to swallow was in fact the pill that she had always been receiving. And so, again, there was a situation of the nurse saying, but Miss Lillian, you've received this for months, and Miss Lillian insisting that it was the wrong pill. The ombudsman then did the very smart thing, which was to ask the resident, what makes you think this is the wrong medication? The nurse is pretty sure it's the right medication. It's in your record. What makes you think it's wrong? And the resident was then able to say, I can't swallow it. And that was the resident's sort of internal proof as to what was wrong. Now, why she was suddenly having trouble swallowing, was she more dehydrated, did she have some new swallowing problems, was something then for the medical team to explore further. And for Miss Lillian, doctor, nurse practitioner, to prescribe a medication for the same reason that was smaller or in a different dose, one that she could swallow and then accept. And this case to me was very instructive because what it really emphasizes are the ways in which you can get collateral information and the ways in which you can reinforce that a resident's truth is the truth. It just might mean something different than we think, kind of at the outset. So that was one where the strategy was to recreate and to keep asking the question of the person, what's wrong with this pill from your vantage point, and what was wrong from their vantage point was that it was too big. Now, let's take another quick situation. This time with Mr. George. And Mr. George is 82 years old. He's widowed. He has dementia. And the problem with Mr. George is that he makes a lot of lewd comments. He swears at staff. He reaches for staff's breasts, bottoms, private zones, if you will. And the staff have not been able to get this particular behavior to stop. And so Mr. George has been seen for some period of time as a problem resident. Got a consultation from a behavioral specialist or from a psychiatrist, somebody on a mental health team. Mr. George is placed on medication. No medication particularly helped him. When Mr. George struck another resident, it led to his receiving a discharge notice. And it was at that point that the ombudsman became involved in this situation. Oops, sorry. Now, the ombudsman is often called in as though the ombudsman is going to somehow help solve the behavior problem. And one of the things that I would like to emphasize is that while you may be asked to solve that problem, your first and primary role is to make sure that however that problem is solved, you are the person in the room who keeps advocating that people actually see who this person is and to try to understand what that particular behavior might mean, as well as how to address it. You don't have to have, in my view, the answers to solving behavior problems. But I would hope that you would be the voice at the table that says, there's a growing body of knowledge that says, using a strength-based approach, figuring out behavior as communication, using non-pharmacologic, that means non-drug interventions, actually has been shown to help. And that, in fact, if the first consult that was obtained only got a drug recommendation, then maybe a different consultation is needed. Maybe we need to take up the individualized care planning differently. And we can talk about some strategies for addressing aggressive behavior, and we will a little bit later on, I'm sure. But at the outset, what I'm asking you to do in the kind of general situations of the Mr. Georges, when they get discharge notices, is to ask everybody to ratchet down the distress a level, step back from it, see who this person is, what their needs are, and in addition, what their strengths are. Most aggressive behavior is fear-based. Most people act up and strike out when they are afraid. Most behavioral situations really require a careful analysis, or what we sometimes call the root cause approach, to figure out all of the contributors to a resident-on-resident altercation. Invariably, those factors will include something going on in the environment, too crowded, too noisy, too hot, too cold, something going on with the other residents, with the situation the resident who struck was put into, either a too stimulating a group or a too understimulating a group, whatever it is. Invariably, a contributor to a situation of an assault will include how the staff handled it. What did the staff do to intervene? Did they make the situation better? Did they make the situation worse? And a contributor will be the resident. But generally, the one piece of that that's left out is what strengths does the resident bring to solving this problem some way other than a discharge? Solving the problem some way other that not only protects that resident's rights, but by analyzing and understanding what triggered the behavior, if you will, and what the behavior is communicating, that resident who is being aggressive can also have a higher quality of life. Because let's face it, the discharge only really temporarily solves the problem, and it only solves the problem for one facility. It doesn't usually solve it for the next person, the next place where that person might go to live. Now, let me say one more word about aggression and about violence, because I know from recent news reports that there has been a very tragic incident in the state of Maryland in which a 92-year-old person has been charged with homicide after he struck another elderly resident, delivering blows to the head that resulted in a subdural hematoma, and the victim of his assault did die, and that 92-year-old person has been charged with homicide. Now, in reading the newspaper story, I was struck by what is often the case in news stories of this kind, in which the person's mental disability is emphasized as if it is a cause of the violence, and the violence itself is sensationalized. And so whenever I see stories like this, I feel like I usually want to comment about violence, is that there are certain things for you to understand about violence. It is an activity that is more likely to be engaged in by younger persons than by older persons. So youth itself, more impulsivity, is a risk factor. A past history of violence is a risk factor. Current substance use is a risk factor across the board, whether you have a substance abuse history or not, but more likely among those who do have a substance abuse disorder. With respect to mental health conditions, the people who are most likely to exhibit what's called violent behavior or out-of-control behavior actually tend to be people who are in a state like a delirious state, like the DT, like rum fits, some period either of intoxication or acute withdrawal in which they have a delirium. In terms of just random striking out violence, that's the group that is most at risk. And the important thing for you to understand about delirium is that it's also a medical emergency. Delirium is usually caused by medical conditions, which, if untreated and the delirium goes on, could result in kind of major harm to the person. It is not the person with schizophrenia, it is not the person with bipolar disorder who is likely to execute acts of violence. It is oftentimes true that people with dementing illnesses, in instances of fear, as I mentioned, will in fact assault another person, but it is not a random, impulsive act. In other words, there's something going on in the situation in which the resident with dementia feels afraid and feels like there is no way out. Probably the best example that you all know of this is when the person is combative with care and is, from their point of view, struggling for their lives, and from the staff's point of view, they're just trying to give them a back. So there are these distortions of the situation in which residents with dementia will be what the media might call violent, that is to say, strike out. But that incident in Maryland was a very rare and exceptional event, and not something that reflects back on sort of everybody of that age who has a dementia illness. The other thing to remember about violence, just as a sort of general truth in our country, is that the people who are at the highest risk are intimates. That is to say, the most likely acts of violence that are committed between two people who know each other and are married to one another. Okay, and I'll answer questions about violence, but I did want to just comment in light of that recent story because it sort of always triggers this extra concern about people with mental illness, and they're not the ones who must have it. So to just recap quickly, in long-term care, the mental health problems that you're most likely going to encounter are dementia, and they're going to be around the behavioral disturbances, the medication refusal because of the wrong bed, or aggression leading to discharge notices, and then capacity concerns. And I'm going to say something about capacity in just a moment. I've raised this word delirium, and so I'm going to just remind you very quickly what it is. I also want to talk about depression and then schizophrenia. Those top three, the 3Ds, dementia, delirium, and depression, account for about 80% of all the mental health problems in long-term care that you're going to encounter. People with schizophrenia or bipolar disorder or other, what we typically call major mental illness, are going to account for the remainder. The 3Ds are the top ones. Delirium, I said, is a medical emergency. It is frequently missed. I recently attended a conference where they were quoting rates of being missed 30% of the time in the best emergency rooms in the country. And it is probably missed because people who don't have a lot of experience working with older people can't tell the difference between delirium and dementia. So here's what you want to be mindful of. In delirium, we're talking about a change in mental state that's characterized by a sudden onset. This is the resident who looked okay in the morning, but by afternoon is acutely disorganized, disoriented, can't focus on anything, has impaired attention, and whose sensorium, or what we mean by that, a level of consciousness is altered so that they're either very unusually somnolent or hyper alert. That's just their general level of awakeness has changed. And that course fluctuates during the day. If you see a resident who has an unexpected change in their mental state and it has 3 of 5 of these characteristics, it is worth noting it to staff, or raising the question, asking somebody to attend, could this be a delirium? The most common causes of delirium are drugs, drugs, drugs. Either drug misuse, by which I mean taking too many drugs, having drug-drug interactions, becoming intoxicated, maybe not from taking too many, but from the dose that's being prescribed being too high. And then interestingly, delirium can also be caused by the abrupt withdrawal of drugs. And the example I've already given you is the abrupt withdrawal from alcohol, which causes something called the DT, or delirium tremens. The other situation in which you see a delirium from a thought withdrawal of medications is if a person, usually a senior, is abruptly taken off the drugs we call the benzodiazepines. That would be Valium, Klonopin, Ativan, Xanax, and so forth. Okay? So the main take-home here is what I see for the ombudsman role is that I want you to be aware that this thing called delirium exists because it can be life-threatening, because it's often missed, because it's one of the top 3 mental health conditions. And if you are in a situation where you can actually do advocacy to help prevent this, it is by having facilities pay very close attention to the manner and the kinds of medications that they prescribe for seniors living in long-term care. But this is largely a preventable situation. It can also be caused by urinary tract infections and by a host of other medical causes. But for today's session, I think I just want you to be aware of how frequently drugs are involved. Now, about clinical depression, the second B, depression, remember, is a medical disorder. It is a chronic condition. It is not a normal part of aging. It is very common in nursing homes. It is particularly common in long-term care among residents who have had a stroke, who have had a heart attack. And it particularly causes disability if people also have diabetes. So what I want you to know about depression is that it's serious, that while common, it's not a normal part of aging, that certain populations, stroke, heart attack, and diabetes, are at particular risk. And I want you to know that depression can be treated, and it's also preventable in the long-term care environment. One of the most serious consequences of failure to treat depression is suicide. This is a growing concern in nursing homes where there have been a couple of high-profile cases, actually one not so long ago in New York State and one not so long before that in New Jersey, which was actually also a homicide where the husband came in and killed his wife, who was the resident of long-term care, and then turned the gun on himself. So this is a growing concern. And what I want you to know about suicide is that people who threaten to kill themselves do kill themselves. There's a myth out there that people who talk about it don't actually do it, but they actually do. I also want you to know that if somebody does threaten to kill themselves and you're the person that they tell, I want you to know that asking them about the suicide does not put the idea in their head. You are not going to, if you're worried somebody might be suicidal, asking them if they have any thoughts about harming themselves is not only okay, it's the right thing to do. I want you to understand that a person thinking about suicide, talking about suicide, may be giving a symptom of depression as much as they are expressing a choice of dying. We're probably not going to have time. In fact, I know we won't have time to get into a long discussion about suicide today. So let me summarize what I think are some comments I've heard from ombudsmen before. Sometimes ombudsmen feel in conflict about this whole area of suicide because everything about your training puts you in a position of advocating for a resident's rights. And people will often get themselves kind of tangled up in the question of, do people have a right to kill themselves? And of course, people have a right to live and do with their lives as they wish. For me, the thing about suicide is not about does somebody have the right to or not, because frankly, they always have the right, and my job is not to take that right away, but to buy them time to see if they want to change their mind. Because most people, we rarely get to ask people. See, the problem with suicide is that it's a done deal. You don't get to ask the person, gee, if you had had a chance, would you have changed your mind? And But the hardest thing, I think, to really know in the final analysis what the person's last thought was. But there was a study done on people who had jumped from the Golden Gate Bridge, trying to get at this, and who had survived that, who by every imaginable observation did intend to die and kind of miraculously survived. And of those who survived that jump in this particular study, all but one said that their immediate thought upon jumping was, oh my God, what have I done? I don't want to do this. And that's not to say that everybody changes their mind. It's to say that suicide is a complicated choice. It's a complicated decision. And about 3 out of every 4 cases, it's a symptom of depression. And when the depression is treated, the wish to die and the decision to end one's life goes away. So I would encourage you to not be deflected by the somewhat academic discussion of is it their right? Of course it is. But that's not really the issue. Thoughts of suicide are a symptom of depression until proven otherwise. Suicide is a permanent solution to what is usually a temporary problem. And the role that I think we all have is in recognizing the seriousness of the threat, asking a person about it, making sure that if they are depressed, their depression is treated, and then they can have the ongoing conversation with their family, themselves, their healthcare provider about whether they wish to end their life. But it's too important a decision to make when you're depressed. So your role in all of this, be aware. Be aware of depression as a common, treatable, preventable problem. Recognize the symptoms. You have a lot of resources available to you if you feel like you're a little shaky on depression. Listen to people who talk about wanting to end their lives. Ask them if they're thinking about it. Ask questions. Educate staff, educate residents, and arrange screening for depression if you think somebody has it. Now let's switch our attention. We've talked about dementia, delirium, and depression. Now let's talk about the so-called major mental illness, people with disorders like schizophrenia, delusional disorder, bipolar disorder, serious personality disorder. Here are some of the common assumptions about mental illness. Somehow people with mental illness are different from you and me, but somehow mental health is not as important. This has been true by insurers, payers, the sort of healthcare system at large. That's changing. We're getting parity, but historically it has been seen as what we get to when physical health needs are taken care of. And we've also tended to think about mental illness as somebody else's problem. Now, here's a common encounter that you'll have, I'm sure you've probably had, about somebody who has schizophrenia. This is a resident, we'll call him Mr. Davis, who refuses his medication. The facility threatens him with an involuntary discharge, saying he has schizophrenia, he's going to get out of control if he doesn't take his medication. We can't risk the safety of the other residents. And you are asked by Mr. Davis to advocate on his behalf. He actually doesn't want to leave this facility and feels like it is his right to remain in his home. So, what might be a starting point for this particular resident? The first thing that I would like you to understand about people with major mental illness is that they are not as different from you and me as sometimes people like to think, or sometimes people behave as if they think. When a person has a mental illness, it is not responsible for everything. People with mental illness have good days, they have bad days, just like you and me. And there is nothing magic about medications and about their ability to keep a person from ever having a bad day if they have a mental illness. Even mental health professionals, I think, have an unrealistic expectation, a set of expectations about how much medications actually add to quality of life for people with a major mental illness. Now, I'm a psychiatrist, as you heard. I believe in medications. I prescribe medications. But what I mostly, the perspective, if you will, that I take is not so much the perspective of saying all people with schizophrenia must take their antipsychotics or X will happen. The perspective that I take and that I really, really encourage you to take in advocating for individual residents is to say, what will this do for this person who has schizophrenia? And what the drugs usually do is to help people suffer from fewer delusions, hallucinations, and disorganization of their thought and behavior. Delusions, for those of you for whom these are new terms, are fixed false beliefs, meaning that these are the ideas and distortions about what is true, what is real, what is not real, that people who have a major mental illness often suffer from. You've seen also people who have fixed false beliefs in people who have dementia, and so you recognize this as a kind of symptom of that particular disorder. Hallucinations are disorders of perception. This is when your senses play tricks on you, when you see, hear, smell, taste, or feel something that isn't there. Delusions and hallucinations are kind of hallmark features of schizophrenia. But again, those of you who have been working with people with dementia know that people see things, hear things, believe things that aren't true all the time. So I think as symptoms, these are not so new to you. What's different about people who have schizophrenia is this is a disorder that typically arises when a person's in their 20s rather than when they're in their 80s. Schizophrenia also affects one's ability to think, speak, or act in logical and goal-directed ways. Now, what I want you to realize about schizophrenia or major mental illness like schizophrenia is what I want you to think about is what it would be like to get this particular disorder when you are in your 20s. If you think about what it's like to be in your 20s, you're sort of on the threshold of your life. You're either getting a job, looking for a mate, going to college, but it is a period of time in which your life is ahead of you, and most people have a lot of dreams, hopes, wishes, and they see them in the future and they see their ability to get them. And schizophrenia stops that dead in its tracks. For people who don't have their schizophrenia successfully treated and who then sort of end up on a track of never being able to pursue their life goals, when you might be meeting them in their 40s, but they're now in long-term care situations, who you're dealing with is a person who had their dreams aborted a long time ago, but it may not necessarily mean that their dreams are dead. I think the problem with people with schizophrenia is that because people with schizophrenia have trouble paying attention, because all of their behavior is interpreted as a mental illness, because this comes on when they're so young, they have a limited reservoir of coping skills, and a limited reservoir of memories, a limited reservoir of friends and other social supports. People with schizophrenia cannot usually be their own best advocates for getting people to talk with them about their dreams, their goals, their future, their wishes. But a lot of times what happens with people with schizophrenia is that people dismiss them as unrealistic, as not a good goal, if you will, or not an informed goal. And one of the primary roles that I think advocates can really play is to help staff learn, and for you yourselves to know, that people with schizophrenia do recover from the illness. Now, that does not mean that they become symptom-free or they no longer have schizophrenia. What it means is that they, just like a person with diabetes, just like a person with any other chronic condition, just like a person on dialysis, can learn to live a higher quality of life and can have a higher quality of life even though they have an illness. When schizophrenia is pushed into the background and life is pushed into the foreground, people with schizophrenia can live and recover. And this is a relatively new concept to come to long-term care, but one for which I am strongly advocating, and one for which we begin to see some minor successes, where in long-term care, the goal of eventually living independently in the community may take 5 years, but it can happen for the person with a psychiatric disability if that's made the goal of the care planning. The biggest problem in long-term care right now for people with mental health problems like schizophrenia is that there is a lot of excess disability coming on top of their underlying psychiatric disability, by which I mean that when people with schizophrenia who have that disability are in long-term care, typically the staff and the system will take away from them their last remaining coping skills by making them follow the institution schedule and not by having a lot of opportunities to really kind of practice their autonomy and decision making. So a recovery model headset is really what we need in long-term care now. Your role, in my view, for this is to challenge people's underlying assumptions about long-term care being the end of the road for people with psychiatric disabilities. Challenge the underlying assumption that somehow people with psychiatric disabilities are fundamentally different than you and me and fundamentally need their own separate, locked, very dangerous kind of facility. Those assumptions are unfounded. I think your role in this is to support recovery and then to advocate for the services that people need to, in fact, recover and to eventually be discharged from long-term care. How do you do that effectively? You know, I think that from go back here. I think that from a system standpoint, the paper that Sarah mentioned in the beginning of this presentation would be a good place for you to start, to look at advocacy on a systems and individual level. But there are other organizations out there like NAMI, the National Alliance for the Mentally Ill, like the National Mental Health Recovery Movement. They have different names in different states. In Vermont, they're called Psychiatric Survivors. But to partner and to pony with other agencies that are advocating for people who have serious mental illness who are in long-term care, to try to shift this discussion more towards a recovery model and to get the services they need. The Olmstead decision, in my view, is being completely underutilized. The Olmstead decision, as you know, basically reiterated a person's right to live in the least restricted environment. It was a case that had to do with persons with developmental disabilities, but has been and can be applied to people with psychiatric disabilities as well. And that's one example of a tool I think that's underutilized. The other is to partner with organizations that are focused on recovery. Now, here are some I'm going to go very quickly because I want to get to your questions, and I have just a couple of minutes of remarks. And if we don't have questions, I'll go back to my remarks, but I really want to hear your cases. Here are some very quick tips, and again, these are also in the Ombudsman Training Manual that Sarah mentioned that you can get from NORC. I want to talk about residents who have hallucinations, delusions, anxiety, not making sense, verbally abusive. These are the various challenges that you might encounter. People who have cognitive impairment, memory loss, disorientation. In other words, people whose communication is impacted by some aspect of their mental health problem. My most important tips for you with respect to communication, because I think ombudsmen are already pretty good at this, is that when you are planning a conversation with a resident whom you know already or have reason to believe may have some cognitive impairment, you want to set the stage to maximize the likelihood of success on both your parts for a positive communication experience. And what does that mean? It means that with your older residents, consider their sensory deficits. How well do they see? How well do they hear? Don't sit with your back to a lighted window where they can't read your lips. Sit so that they can see your face. Speak in a low, sort of normal volume And by low, I mean tone, but speak in a normal or just slightly louder voice. For older people, make sure that they can hear you and check their level of understanding by saying, yeah, do you understand what I just said? Always sit face-to-face with people. There is, for people living in institutions, a perceived lack of power, a kind of one-down position. This is true for people with psychiatric disabilities or people with dementia. Sit face-to-face so that you are perceived as equals, and keep a respectful distance so that you are neither intruding on space nor at risk of being hit if the person becomes agitated in a conversation. Commit to listening, allow time, be patient. Insist that there is private space is provided for you and as quiet as possible. Let everything about your body language, your gestures, your tone, communicate that you respect this person as an equal and as a person first and not a person with a disability. What helps for talking with people with depression is to listen actively, to be the keeper of the hope. And one of my favorite phrases for reminding people about the temporariness of depression is to say, I know you feel this way now, but you won't always. It doesn't help if a person is depressed. Cheer up. It doesn't say, you don't have help to say, oh, it's not so bad. It is as bad as the person feels that it is. Our job is to remind people that it won't always be that way. That's just a little tip on depression. Talking with people who have schizophrenia, be patient. Signal your confidence that they can recover. Hope is the message here, just as it is with depression, and listen actively, meaning always checking in, did I get that? Is this what you meant to say? Did I get that right? When you are concerned about the other person's fearfulness, and if they are fearful, then they're more likely to become agitated. Remember, aggression is fear-based. Make sure that you don't use gestures which threaten. If you're a person like me who talks with your hands, keep a distance so the person never feels like you're about to strike them with your hand. Don't touch people without their permission. Quick word about capacity. There's a difference between capacity and competency, and I just want to make sure that we all know it. Capacity is task-specific. Capacity refers to the ability to do something. It's not a global finding. It's not, well, this person has or doesn't have capacity. We talk about the capacity to make a will, to make decisions, about your finances. There's capacity to make decisions about where you're going to live and so forth. It's situational. It's contextual. And a person can have impaired capacity in one area, like no longer be able to do their finances, but be perfectly able to say where they want to live and why, and to reason decisions about their living situation. Competency is a legal construct. Competency is like innocence, something you have until you've proven not to have it. Only a probate judge in most states can take competency away. It is a global legal statement, but capacity is task-specific and situational. Also know that capacity can fluctuate. See, oftentimes you make, even without thinking about it, decisions about whether a person has capacity just when you're trying to make sense of a communication they've given you, and as to its accuracy and its reliability, if you will. Will they say the same thing every time? Is what they're saying both valid and reliable? Over time, do they reason situations in the same way? And do they understand the task at hand? These are all the issues related to capacity. And when you are deciding that, you are deciding it in the moment. It is not a global determination. And also know that because it fluctuates, if you have doubts about a person's capacity, like did they really understand what they were telling you and was that really the decision, you can go back another day and repeat your conversation and your questions, and you may find that their capacity in that moment has improved or, on the other hand, become more diminished. Those are just more on capacity, or to skip over those slides. Okay, I wanted to allow 30 minutes, but it looks like I've allowed 20 minutes. So let me stop there and ask you to ask your questions. Remember, to do so, you're going to want to press *1, and then an operator is standing by to assist you.
At this time, we are ready to begin the question and answer session. If you would like to ask a question, please press *1. Please unmute your line and record your first and last name. When prompted to withdraw your request, please press *2. One moment, please. Our first question comes from Ana Dominguez. Your line is open.
I'm from El Paso County, Texas, and my question is regarding a discharge notice on a schizophrenic resident or a resident who suffers from schizophrenia, where the doctor, they failed to go ahead and prescribed Haldol. The resident, prior to going into the hospital, prior to going into the nursing home, had undergone breast surgery, which is what necessitated her going into a long-term care. And she had been residing at home and was taking Haldol. However, the nursing home failed to go ahead and administer the prescribed medication for the schizophrenia. What can be done when they refuse?
When the nursing home refuses to prescribe medication?
Yes, ma'am.
Okay. Well, first of all, let me ask you something. Where does this resident wish to reside?
Well, the problem was that because of medical necessity, she was placed into long-term care. She has a guardian. She has a guardian, first of all.
Okay.
So there's been a finding of no competency or legal competency. Okay.
Okay.
She has a guardian who's her sister.
Okay.
And following the surgery, the breast surgery, that is what necessitated her going into a nursing home. Problem is that because of the lack of prescribed medication, she supposedly had aggressive behavior and inappropriate sexual conduct, which supposedly then gave rise to a discharge notice. And now, unfortunately, this person is at the psychiatric center.
Thank you very much for sharing this experience. Let me take the question as you asked it. How do you get an appropriate medication prescribed for a person? In this situation, it's kind of hard for me to know because I can't imagine a situation in which a physician would refuse to prescribe the correct drug. Let's imagine for just a moment that she had just come from heart surgery and she had a heart drug, and the nursing home saying we refuse to prescribe it. So you see, this is what I mean about making people with mental illness so different. If this is a person who has schizophrenia and whose schizophrenia was well controlled such that she could live at home independently in the community on Haldol, then that drug is as life-saving to her as a heart medicine would be. So how do you advocate for that? I think this person having a guardian should have put that guardian in the position of calling the original prescribing psychiatrist and getting that psychiatrist to speak with the prescribing physician in the nursing home and making sure that that doctor knew that this person needed the Haldol. Do you know if that happened?
Oh, well, yes, there was continuous dialogue, and this person, the resident, was a client of the local mental health, mental retardation authority.
Okay. And so the dialogue happened, but how can a nursing home refuse to administer a medication that is prescribed? Maybe you can help me understand that. In other words, is the issue that no doctor would prescribe it or they refuse to administer it?
Well, it's my understanding that the medical director does not usually subscribe to going ahead and administering Haldol, prefers, I guess, to he prefers for them to be placed under something else.
I see.
But that sort of fell under the cracks as well,
Yes. I think I don't want to do too much empty speculation, but, it's possible with that piece of information that the medical director is simply ill-informed. Haldol is a drug that over the years has gotten a very bad reputation. And Haldol got a very bad reputation because it was either prescribed in too high of doses or prescribed for long periods of time, or it was prescribed for people who didn't have major mental illness, namely people with agitation and dementia. But Haldol is actually a perfectly respectable drug for people who have schizophrenia. Mm-hmm. And even though the pharmaceutical industry would have us believe that Haldol is out and the atypicals are the only drugs in fact, in the last big study that was done, something called CATIE, we should all write this down, the C as capital T as in Charlie, A as in Apple, T as in Tom, i.e. the CATIE study actually showed that old drugs like Haldol are just as effective as the new super expensive drugs, with this caveat. Older women may be susceptible to having tardive dyskinesia, that movement of your mouth and tongue. Now, here's the other caveat. For a person who has been maintained on Haldol and doing well, it absolutely is the drug of choice. So this is what I mean about having person-centered care. If you were to ask me, is Haldol a good drug for older people living in long-term care, I would say generically, no. It has a lot of side effects. If you would ask me, for Mary Jane, who has schizophrenia, who's always taken Haldol and done well, could she be on it? The answer is absolutely yes. So now, that's point number one. So I think what slipped through the cracks here was anybody adequately ratcheting up the dialogue with the medical director by having, a psychiatrist call the medical director and say, I will be the recorder or the prescriber of fact for this person because she needs her Haldol. We know her well, and to kind of have it out at that level. And perhaps an ombudsman, but in this case, even more appropriately or equally appropriately, I think the guardian was the person in the best position to insist that she receive her Haldol. Now, the second part of this, of course, is that the sexual behavior and the aggressive behavior is being attributed to the failure to take Haldol. And that, I think, is an unproven connection. Just as I was saying about the sort of people having good days and bad days, it's quite possible that there were other things in the environment that were causing or contributing to these unwanted behaviors on her part. And the reason I started by asking, what does she really want, is that, frankly, people with major mental illness who have been institutionalized learned a long time ago that there are certain behaviors that will get them kicked out of wherever they are, guaranteed. And if push comes to shove, those are the behaviors they will display in order to get out of a bad situation. So this case, I think, might be instructive for you to do more like a root cause analysis, to look at all of the factors, not just assume that it was the Haldol. But to your question, when there's a drug that a person needs, going directly to the doctor, the person with the most authority, the resident themselves, their guardian, their family member, or you, going down the line, kind of not let go of that bone until the doctor comes up with a better alternative or accepts the drug. But then I guess the final thing is when in doubt, turn to some of those mental health resources. There's also an excellent resource published by the National Institute of Mental Health. So if you go to N as in National, I as in Institute, M as in Mental, and H as in Health, NIMH.gov, they have just re-edited a publication just called Medications, which has A to Z on psychotropics, and it's a great resource to give to nursing homes when medical directors give opinions that may be outdated.
Okay. Well, thank you very much.
You're welcome. Good luck. Thanks for your question.
Our next question comes from Susan Connorelli. Your line is open.
Thank you. Many nursing homes in the state of Missouri do not have counseling service for our mental health clients. How can we encourage psychiatrists or psychologists to go into these facilities? What would be the best route as an ombudsman to try to encourage them? Or would that not be our role?
You all could probably tell me better than I can tell you what your appropriate role is. My opinion is that's an excellent role for you, and I think it's a hugely challenging. It's hugely challenging in every state. There are many barriers to providers wanting to go into nursing homes, and the Medicare reimbursement is one piece of that. So at the most global advocacy level, keep the voice of long-term care and mental health in the current health care discussion and in any of the discussions about Medicare parity, because right now it is very hard to get mental health types in providing counseling services for seniors, period, and in long-term care in particular. Having said that, there are strategies, I think, within state-funded homes, or in homes in which there is a local medical school, university, or institution of higher learning that has schools of psychology or for mental health training or social work and a medical school. In the state of Vermont, this is one partnering model that we use to have nursing homes actually be sites of training and of learning for people who were in were in their family practice residency, and then were supervised by psychiatrists from the university. So this both provided a learning environment for them, a supervisory opportunity, and an opportunity for residents of facilities to get services. So by residents, in the first half, I meant interns or people in training for medicine. So one partner, I think, at the systems level is going to be the university. In many states, this is a place where I would definitely be looking to partner with the National Alliance for the Mentally Ill to see also what resources or ideas they might. I'm suddenly getting those.
I have a helicopter going over my head.
Oh, okay. I suddenly had just like all this feedback I couldn't really hear. Okay. Now, interestingly, we have just had move into Vermont a company called Deer Oaks. I have no interest in them. I have no idea if they're any good, but I'll tell you what they are and what I think might be a new business model of the future. Deer Oaks is a psychological company. I think they might be out of Texas. They basically hire people locally in states to provide counseling services under contract with Deer Oaks. So, for example, Deer Oaks, it provides psychological mental health services for nursing homes. The way it works here is that if any nursing home in the state of Vermont that has a contract with Deer Oaks wants a counselor, they fax a consult request sheet to this company. This company calls one of its 10 employees or subcontractors and provides for a private therapist to go in and provide that service. Now, again, this is not in any way a plug for Deer Oaks. I don't even know if they're any good. It's a plug more for the modern. See, it's been really hard. One of the things that we've tried is to see if we couldn't get a pool of clinicians who were interested in doing exactly what you say, provide counseling services in nursing homes. And everybody says it's not cost effective, the payments are not high enough, and it's inefficient. But what this company has demonstrated is that if there is a certain volume in the facility, and if the private practitioner does this as one aspect of their work rather than as their whole job, in fact, not only is it very satisfying work, but it will be financially rewarding. So, we're starting to look here at a private, look at all the private opportunities that are available. We're looking at all the public opportunities that are available, and simply trying to expand the way we think about this. So, if there are any comparable companies, I would at least investigate them. Again, I don't know if they're all created equal, but it's a model. But this is one where you need partners in advocacy, and NAMI and mental health recovery movements are the two that come most immediately to mind. Anybody else on the call have any suggestions for your colleagues from Missouri? Things you've tried in your state?
Susan, this is Sarah Hunt.
Hi, Sarah.
Hi, and I don't have new ideas, but I do have by necessity, it's about time to wrap up the call. So I'm thinking if people do have ideas, they could email Melissa, and we could easily share those with everyone who's registered for the call. But I think we're probably at the 4:30 break point. Do you have a final remark you want to make before we conclude?
I guess the only final remark that I want to make is if there's anybody waiting to ask a question, my email address is S as in Susan, Wehry, my last name, Wehry, MD, as in medicine doctor, at mac.com. I don't think I put it on this page. Here's my closing. Write me your question. I'm sorry if we didn't get to it. I'd be happy to offer you my thoughts. Here's the take-home. Mental health problems are common. You already know that. Your job, I think, is to continue to recognize them, to advocate for adequate referrals, adequate services, to refer people, even if the service isn't there, to keep pushing the system to call the facility's attention, call it to the facility's attention when someone has a mental health need. And remember this distinction between capacity and competency, not make it global. It's okay that it's difficult. It's really crucial to help protect a person's capacity. Here are the resources also on your screen. Sarah mentioned these at the beginning. And I've mentioned them throughout my talk. Please use them to augment what we've talked about today. And just let me thank you so much for your participation. I hope it was valuable. I'm sorry we ran out of time, but let's keep the dialogue going. Thank you very much.
Thank you, Susan. You've given us a lot to think about, and just in hearing you go through the points, I've rethought some other situations and application of ombudsman skills. So it's been a very beneficial afternoon and presentation. We thank all of you for tuning in, and we will have this PowerPoint up on the website. The final slide, as Susan mentioned, has a number of resources. She gave you her email address. If you need it and for some reason didn't get it, you can contact Melissa or me or Nork, and we'll be glad to send it to you. Susan, thank you so much for your work and your time and sharing with us this afternoon.
You're welcome. Thank you.
That concludes the call, and I believe Melissa sent a survey around, and we would welcome your feedback, not only on this call, but it will help us plan future calls. Thank you and goodbye.
Bye-bye now.
Thank you.
Thank you for participating in today's conference call. You may disconnect at this time.